So this meeting, we have the actual contract. The task force members were emailed a copy of that contract earlier in the week. And so what I would like to do is, I'm going to presume that people had a chance to look at that. If they've got any questions, we'll discuss those. If we need to, we can have Jill or Marty handle the details. So at this point, does anybody have any questions or comments on the contract? And I'm going to make sure I look to my left so I don't miss any hands if any hands go up. Representative Gray.
You have to push, there we go, push my button. I guess one of the things that I just wanted to ask in the last, when we were approving the motion to start with is, it's my understanding that sole source contracts, and I think the Stephen Group's done a wonderful job, but I think to me, a sole source contract is something that cannot be provided by any other vendor, and the implementation of this is something that can be provided by another vendor. I just want to, I guess, understand why we're doing a sole source contract and not actually putting this out for bid. If someone could please answer that for me.
Well, what I'm going to, Jill, if you would kind of make your way into maybe Phil's chair so you can help me with the answer. Because I think there are two parts to your question. Number one are the technicalities of when is a sole source contract allowed, and I'm going to have Jill address why technically a sole source contract is allowed in this circumstance. And then the second question is the more common sense or substantive answer, which is, could another person implement the thing? And I think from a substantive common sense standpoint, another person, could physically do that, but the amount of getting up to speed, research, learning, also the heart and soul that would go into implementing somebody else's recommendations, I think were factors that in some of the discussion last time, although it wasn't very thorough, I agree, really led people in a pretty hearty vote to support this. Jill, if you would just address the technical aspect of that, I'd appreciate it.
Sure. I think that the legislature has its own procurement process, and whenever this task force voted to take this up as a sole source, that was really all the authority that you needed to be able to do that. I think that the reasoning behind it was that it was just May when you went through the bid and the RFP process. The belief was that if you instituted that same process again at this point, one, your time frame is very short to get your December report completed, and also that you would most likely hear from the same vendors again, and so I assume that that was taken into consideration in that vote.
Okay, well, and that's part of my concern is, PCG was our second choice, and their total was a little over $2 million. So if I take the first, if I take the 1.087 million that we're going to pay out to the Stephen Group, and then I add another 1.087 million, there is no difference between that. And maybe this is just for the task force. There is no difference between that and PCG, but that was a lot of people's concern, was spending $2 million. And I just think, I guess just my concern is taxpayer money. And if we were to bid this, it's possible we might come in at 800,000 instead of $1,087,000. That's it. And just for the record, I did not vote yes on the sole source contract. Thank you.
Excellent points, and the way that this contract is constructed is the maximum is the numbers that you just said. So the more things that we ask the Stephen Group to do, the more billable hours we're going to have against this upcoming contract. So to the extent myself, like you, and I'm sure many others are concerned about the cost, the number one thing that we can do to reduce the cost is help not require as much of their time, travel, etc., so that the billable hours against the allowed amounts are lower rather than higher. Obviously, there's a creative tension there between the work and their ability to do good work. But I think your point about this contract now being virtually identical to the price of PCG is a good one. And as you know, I voted with you for PCG originally. Are there other comments on the contract for the Stevens Group in the discussion? If Senator Rapert, you're recognized. Go ahead, you should be on.
On. There
There
we
you
go.
go.
Well, all I will do is say to your last comment is echo the fact that, yes, I was with you on the original vote as well. I feel like in this particular situation, definitely having gone through as much as we have, the horse has left the chute, and we're on the horse, and I don't see any reason at this particular time that we need to change and go again. So at the proper time, Mr. Chairman, I'd make a motion that we approve this extension.
Thank you, Senator. Are there any other questions or discussions? Seeing none, we have a motion to approve. Can I get a second? Representative Farrar seconds the motion. All in favor? Aye. Any opposed? The motion carries, so the contract is approved. The second piece of business that we need to agree to today is the acceptance of the final report from the Stevens Group. And as you recall, at the last meeting, we approved an amendment to the Stevens contract because there was some data that was not released to them at the time that the initial data was released to them. Therefore, when they did their scrub, they did not have all of the records from which to do the scrub, and so they just needed some extra time to get that done. In the addendum to the contract that we approved at the last meeting, we set it up that they would have penalties against them in terms of withholding of pay and other things of that nature if they did not get that additional information into DHS. I've been informed that they have done that, that is complete, and so now, along with the other report that we've just received and that the Stevens Group has just walked through, what we'd be voting on is an acceptance of their report and the obligations of the first contract that they agreed to last spring. So is there any discussion on agreeing that the Stevens Group has met all of the deliverables that they owed us from their first contract this spring? I see no hands going up for discussion. Can I get a motion to approve acceptance? Senator Cooper moves that we approve acceptance. Representative Farrar seconds the motion. All in favor? Any opposed? The motion passes. We have approved acceptance of the Stevens report, meeting the obligations of their first contract. We've also approved the second contract, and for those that were concerned that perhaps the Stevens Group was not going to be here at these meetings moving forward as we continue to discuss these recommendations, you know, that I don't think there's any concern that that's going to be a problem. Although obviously the contract we just approved needs to go through ALS for final approval. And with that, what I'd like to do is start the task force member questions for the Stevens Group, unless, John, you thought of any additional elements of wisdom you wanted to share with us prior to the questions.
No, we can just get started on the questions.
Okay. Senator Rapert, you had mentioned to me earlier that you would like to ask a question, so let's push your button so we can take you first, and then we'll go in order as the questions come on the board. Senator Rapert, you're recognized for a question.
Thank you very much. I will respectfully just ask one question now and get back in line later, Mr. Chairman. I've got several here. There are several things I wanted to ask, but one thing that did stand out to me that I did want to ask about is it related to the health savings accounts. And I'm trying to find that again in my slides here. I believe that you were, my impression was you were particularly negative. It's very obvious that there's been low utilization.
Correct.
Low participation utilization. However, then you include that in a recommendation not to utilize them.
Right.
Respectfully, that seems to go counter to the general progression around the entire nation that these are being used. So I wanted to make sure that the committee is getting the right feedback from you. Are you saying that, are you just saying it's negative that they haven't been utilized, which I agree with you, or are you saying scrap the utilization of them altogether?
I mean, I strongly believe that health savings accounts work. and they're a good way of encouraging good behavior, incentives, but it needs to be structured in the right way. It wasn't structured really in the right way. It wasn't geared towards any type of incentives for good, healthy behaviors. So, and then the participation rate is so low, so that's what we're responding to. And
Okay.
another way could be constructed, but I will tell you, they've been very difficult in constructing HSAs in the Medicaid program.
And that's where, that's maybe where I'm needing to hear. Because I know on the private side, where people are paying for their own
Yes.
insurance premiums, there seems to be a great affection for them. Because if they're not using that money gets to stay in their account and accumulate over time, and they ultimately could utilize that for other purposes if they needed to.
Correct.
But, so you're telling me is there no utilization in any other Medicaid program?
Very
of-
low. In a couple states, they've tried it, and again, they're not seeing as great an effort. Indiana's probably the best example. And even in Indiana, you'd have to ask the carriers, carriers that are in your state that I think have Indian experience. I don't think it's structured so that they take that many benefits, but there's no incentives, really meaningful incentives, and there's not a lot of risk and not a lot of stake in the game. And that's why HSAs have been successful.
And it seems to me that especially when you've got somebody that either has no income or very little income, they don't have any dollars to put toward that. So I'm
Correct.
with you on that. So at some point, I'd like for us to dig into that a little bit more. I think it's the dynamic of the population that's using it.
Yeah, I will say, there was, state of Pennsylvania had an RFP they were putting together a few years back. In fact, Bob Chin here worked on it. And one of the things that they were trying to do was reward healthy behaviors and have an account available that if that individual chooses, has their flu shots, takes their child for immunizations, visits primary care, if they do the wellness, they were actually given an account where there would be funds available, like an EBT card, where they could use for health benefit, or you can even buy a bicycle for children, whatever it was, but it had to be based on the UPC codes used for just that purpose. But even that wasn't going to carry on into, non-Medicaid if they move beyond Medicaid.
Well, Mr. Chairman, thank you. There's several of us on this task force that serve also on the public school and state employee task force. And HSAs have been a big discussion and encouraging people to use them. I guess really I just wanted to put down a marker to say that just because it may not work for the Medicaid population does not mean that we need to begin to disincentivize it on the employees that also are state concerned. Thank you, madam.
All right, thank you.
And we'd be happy to dig into that even more.
All right, thank you. Before we go to the next question, I just wanted to tell those who have asked, the slides are on the website now. So if you have been asking about that, they are on the website now. All right, Representative Meeks, you are recognized for a question.
Thank you, Madam Chair. First question is going to be on slide 48 on your organizational chart. Just for reference, and again, I'm just trying to get some information about the organizational chart because I kind of find it ironic. We have been trying to improve our foster care system, Department of Children and Family Services, and one of the recommendations is potentially down the road to take the Department of Children and Family Services and moving it out from under the Department of Human Services. In your chart, I do not see the Department of Children and Family Services listed at all. So is it underneath a category maybe that I don't see, or would your recommendation actually be to move that out from underneath it because it's not directly tied to healthcare?
It's a great question. We don't make any recommendation on children, family services, where it should be housed. What our slide is to elevate Medicaid to being more of an integrated department division. It could be separate standalone. It could be taken out of DHS as long as behavioral health, long-term care, and development disability is within its structure, structured like a health plan. But there needs to be, Representative Meeks, in that situation, good integration with Child and Family Services. In Mississippi, the model is DHS does the Child and Family Services and also does SNAP, TANF, and Medicaid is in a whole separate department. You could have it as a cabinet, but really to pronounce your Medicaid department in a much higher profile.
Okay, thank you. And then a second question is under slide 35, under the shop marketplace. In your slide, it says currently FTE max growing to 100 FTE in 2016. It's my understanding that Congress has actually gotten together and done something. They've passed a bill that would keep that number at 50 FTE max. Are you aware of that bill? It's apparently sitting on the president's desk right now. And if so, does that change any recommendations in there?
Yes, we were actually aware of that, made aware of that today. We looked, I believe, on either the CMS website or some of the instructions indicated they were moving to 100. And if there is congressional action to stop that, understand that our recommendation to you is to put the SHOP program into a 1332 waiver. So you still could have the benefit of negotiating a waiver to increase it beyond 100, and also base it on the level of income of the employees as well. So there's we believe you have some flexibility, even if the president signs that bill.
And keeps the FTE max. You
At
think that
50.
there's maybe some negotiation that if 100 is in our
Yep.
best interest, that we could
Yeah,
give
and
it
I
to
would urge you to we'll continue to look at that, but I would think that's where the 1332, some of your focus should be.
And do you have a number? I mean, because you mentioned 50, 100, is there some studies or some data that would say this is the right number for Arkansas, whether it's 50, 75, 100, 150?
We don't have that analysis. We based it upon income. So we will do that. We can have that information for you. But we don't think it should be set at an arbitrary number. It should be set at the amount you pay for those employees. And that might be something that CMS would be willing to accept.
Okay, thank you. Thank you, Madam Chair.
All right, thank you. Next, Senator Cooper, you're recognized for a question.
Madam Chair. Over here.
Yes, Senator.
On slide 7, you said episodes of care is a national best practice example, but the return on investment is unclear on that. And then on slide 39, there was another reference. You said rescind the EOCs for primary care over there. So can you pull all of that together for me? It seems kind of maybe contradictory.
So the last bullet on page 7 regarding the episodes, that's intended to be two separate comments, that it has been recognized nationally as a best practice. It's been highlighted in a number of journals and conferences. But at this point in Arkansas, the ROI in terms of money saved versus money spent is unclear. It's still very early in its development, and based on actual experience, that the ROI could swing positive or negative. And then on the other slide, it was 39. The recommendation there is specifically for those episodes focused on primary care. What we heard from the community, what we heard from providers, and just in analyzing the programs, it appeared that there was perhaps too much being put on the primary care physician community in terms of having one set of requirements and drivers for the PCMH program and another separate set for the episodes of care program for certain episodes. So we recommended taking, if there are certain metrics or requirements that we want to drive toward the primary care community, to push it through the PCMH program and not the episodes program.
Okay. One follow-up. I have several questions, but I'm going to let somebody else ask some, and then I'll get back in the list later on. The 1332 waiver that you were talking about in answer to the previous question there, would whether it's a federal exchange or state exchange, have any bearing on that waiver?
We're looking into that, but it should, from evidence that we've seen so far, it doesn't have a bearing. But we want to double check that question because it was raised with one of the senators.
Okay. Thank you. Thank you, Madam Chair.
All right, thank you. Representative Ferguson, you're recognized for a question.
Hello. Oh, thank you, Madam Chairman. On page 39 also, how would you expand the patient-centered medical home into all Medicaid PCPs in high-cost areas? I'm a little, I'm not sure exactly what you mean by that.
Let's start.
As originally envisioned, the healthcare payment improvement initiatives, which included the episodes of care and the patient-centered medical home, also included a concept for the high-cost populations, which was specifically targeted for the elderly and individuals with developmental disabilities, individuals with severe and persistent mental illness, and the developmentally disabled. And that was targeted around an analogous concept, not exactly like a patient-centered medical home, but in the same way, having an entity or individual be responsible for the total cost of care for each patient. And it would probably be structured differently, but as it was moving forward, that initiative did not in fact get implemented, but this recommendation is essentially that or something like it should in fact be implemented for all populations.
And I mean, I've made no secret that I have some real concerns about managed care. So if we expanded this patient-centered medical home model, like you gave us three choices, right? The care management, the hybrid, or the managed care. And it concerns me too that, I mean, we didn't talk about any of the bad parts of managed care and the problems that other states have had with reneging on contracts and not following through. So, and also that those jobs are going out of state. If we can do it with a patient-centered medical home in state, I certainly would prefer that. You talked about a comprehensive individual assessment. Can you expand on that a little bit and tell me about that for these high-cost groups?
CMS requires for home and community-based services waivers, which are the waivers that you have for your elderly and physically disabled population and people with intellectual and developmental disabilities, what's called an independent assessment. And under the rule, independence is defined as not having a financial interest in a provider or receiving pay from a provider that would be paid based on that individual assessment. So what we're recommending here is that the assessments for your home and community-based services programs, and assumedly if you kept it under a PCMH model, you would more than likely remain with your numbers of waivers, that become independent. Right now, for your home and community-based services for the aged and physically disabled, you have state nurses doing that, and they're quite competent, and that legally would constitute independence. As you know, for people in the community that are in hospitals, almost all of the assessments are done by nursing facility professionals who are credentialed and also do excellent work, and it's done on two different forms. When the criteria for home and community-based services is identical to the criteria for nursing home admission. So that we would recommend be an integrated assessment instrument, whether it be the NRAI or another one, a credible one is a secondary issue, but it does need to be the same one. For the folks with developmental disabilities, we would just recommend that's being done now by state nurses as well, state qualified personnel. So that also meets the independence. Right now, for your RSPMI benefit, you have the providers of services doing the assessments, and there's no standardized assessment instrument which would indicate acuity levels. As we've reported for the RSPMI benefit, the provider provides historical data, demographic data, whatever medical prior history knowledge they have, and they do an assessment based on a face-to-face. Doesn't need to be signed off by a physician. So there's no assessment in your RSPMI benefit that we would consider to be independent, nor would we consider it to be best practice in terms of clinical differentiation of levels of acuity.
Could I ask a follow-up? The other, it talks about federally qualified health centers being moved to the patient-centered medical home model. I'm sort of confused about that. I know now because they get paid on a cost basis, reimbursement, are you talking about paying them additionally, the per member per month and the shared savings? Or are you talking about, I mean, I don't know even federally if you could restructure how they're paid.
We have not made any specific recommendations about how they should be brought into the patient-centered medical home, but we did, particularly in our conversations with providers and folks in the communities, come to realize the degree to which the FQHCs do serve as people's primary place of to receive primary care, and so it seemed like something that that should be strongly considered, and if possible, and if we can work through it in a way that makes sense with on the financial side, in term as a adjunct to their current payment models, something that should be done.
Okay, thank you.
Representative Boyd, you're recognized for a question.
Thank you, Mr. Chair. I think I have 2, maybe 3, all related questions. Is that all right?
Yes.
Okay. Thank you. There's some good recommendations here for pharmacy, and I appreciate those. A couple of them, when you presented them originally, I didn't see the point in waiting, so I've already talked to Medicaid about them, like expanding the PDL list and enhancing the access to the prescription drug monitoring program. So again, thank you for bringing those to our attention. So my questions are on page 42 of your report recommendations, volume 2. You list the amounts paid for brand name private option claims and brand name traditional Medicaid claims. And so one of the questions I have is, basically, are we comparing apples to apples in the sense of, hasn't there been discussion that traditional Medicaid has sicker patients than the private option patients? And so possibly we are not really comparing similar populations, and so there might be a difference in the product mix?
What we did at the start of the analysis is we set about to try to remove biases like that. We didn't analyze 100% claim set from the private option carriers or the state. We took all of those claims and created a most comparable data set. And in the details of the findings and the query plan, we describe which types of claims were removed. But here's a simple way to think about it. If you were one of the small private option carriers with not a lot of lives, therefore not a lot of pharmacy claims, if you had just a couple of, the very expensive specialty products in there, and in the end, as we chose to do in the report, we were going to report on averages, those couple of claims could have skewed the averages. So we took out specialty claims and claims that could have caused biases for dollars. I would say, Representative Boyd, we did not take out, we didn't adjust for claims mix based on acuity for more commonly used products.
Okay, so there's not a claim necessarily a claims mix for I've got this diagnosis and this is how I'm treating it, and so there's there could be not an apples to apples. It could be an apples to pears type comparison to some degree.
To some degree, yeah. We took great pains to remove the dollar-based ones that would have really skewed mathematical averages.
Okay, so the second part of this question is, and I think it's an important part, and I hope you have an answer here, is when we're looking at traditional Medicaid, there are significant reimbursements that the Medicaid can receive. So are we looking at this is what is actually paid to the pharmacy at the point of sale, or are we actually comparing the absolute dead net claim cost, what it truly costs the state or the taxpayer?
Great question. Details are provided in the report, but I have them right here. The only things that were compared were the total amount paid, so the amount reimbursed for the ingredient, and the dispensing fee. So we looked at by drug class, the total amount paid, the dispensing fee, the claim count. Those were the only items that were used to arrive at the average. Rebates, as we talked about in a previous meeting here, rebates are paid in arrears and are very hard to bring back and tie to individual claims. So we're analyzing 2014 calendar year data. Some of those rebates may not even have been paid yet, may not, through the end of this year. So it is not a dead net comparison, what's paid by taxpayers after all rebates are accounted for. It is the data elements I described in the report.
Okay, so basically, it's a very complex system, and there could be a formulary bias that is not accounted for based on rebates. For instance, brand name attention deficit disorder drugs that Medicaid wants us to use, whereas the private option plans wouldn't because there are deals cut on the back end. Is that a correct way to say it?
It is in the findings, and the way we accounted for that in the recommendations was we didn't recommend doing anything with the generic drug reimbursements, understanding that there are times when the state actively chases brand name drug dispensing because the brand name reimbursement less the brand rebates net less than that same comparison on the generic side. So we did try to recognize that in our recommendations.
Thank you.
Okay.
Representative Gray, you're recognized for a question.
Thank you, Mr. Chair. All right, real quick, a couple of questions. I was looking at page 45, your rebalancing long-term services and supports. One of the questions is, I just remember from one of the presentations we had previously, it showed from like 2010 or 2011 a steady decrease in the number of nursing home days that were billed for. Went down like 2 million or something like that, if I can remember correctly. So I'm trying to figure out, in prior presentations, we've seen how the state of Arkansas has been able to, and the nursing homes have been able to manage themselves and actually reduce their number of days. But according to this chart, you're showing almost a 30% increase in the census, which is the number of patients in a 6-year period. So where did you get your data from?
So for the estimated 2015, or I'm sorry, in looking at 2015 until 2021 in terms of the overall population that is going to be served by long-term care, that is derived from the estimate or the projected population growth in the over 65-year-old category, and then combined with the balance of nursing home versus community-based care. So if we look at the estimated to 2021 without rebalancing numbers, going from census of about almost 12,000 to about 14,000, that is about a 3% annual increase in the over 65 population, assuming for that projection that the balance of nursing home versus community-based care remains the same at about 65% spend on the institutional side.
Okay, well, it's actually like if it's 6 years and it's 30%, it's like closer to 6% per year increase. I just want to know, did you take into account the state's actual historical data of reducing their nursing home total days billed? Because if you took the historical, has our historical been 6% growth per year?
I'm not familiar with what the historical has been. This is just assuming an over time shift in the overall spend from the current proportions to the national average.
Okay, so is there any specific place where you got this data, I guess is what I'm asking?
Yes, I can answer that. That was from the department's decomp reports, and we can address that question. We can get you the historical that we looked at, so I wrote that down. That'll be
Okay.
subsequent.
Thank you, that's all. Will come back to me
Yep.
after a while.
Senator Cooper, you're recognized for a question. I realize we're now getting into second questions for the committee members, so we'll open it up to any legislators who have a question.
Thank you, Mr. Chair. You mentioned a while ago the pharmaceuticals, and I think we've all heard about some very high prices on some pharmaceuticals in selected areas. And there's been some that have gotten a lot of attention along that regard, but some of those, as it maybe sounds strange to a lot of people, are actually generics, where people or companies would not have a competitor, and it may actually be something that's on the market for years, and then suddenly it has a high-value application, and they raise the price significantly. Along that line, is there anything that we can do as far as joining with other states or with other buyers to handle that in those selected? And I don't want to imply here that that I'm anti-market here, because I think we all recognize there's a very good and essential place for R&D in developing new, but also there's the possibility, and the actuality does exist, that sometimes people gouge the market.
Well, good news or not, over the last 3 weeks, we saw a primarily financial investment in an old drug, and then a subsequent 5,000% increase in the cost of that drug to the market. There are no other sources for the drug, so the market has two choices: pay the overinflated amount or don't use the drug. And the drug happens to be really effective for toxoplasmosis, so we probably are going to choose to use the drug at the inflated rate.
Is that Turing Pharmaceutical?
Yes, sir.
Okay, thank you.
In the ensuing just very few days, 48 hours after he made his announcement, he was publicly shamed by both PhRMA, the trade organization for major pharmaceutical manufacturers, and BIO, the trade association for biopharmaceutical manufacturers. And BIO actually kicked his company out from membership. So I think he's been shamed. He's announced that he's going to rethink his pricing position, although he hasn't announced what that's going to be. But what could we do jointly? We asked for an interesting rebound in a market, in a public market, by always asking for lower and lower and lower and lower generic drug prices. And we got that. We got prices, that were a penny a pill for certain generic drugs. And the prices got so low that manufacturers of those products refused, they weren't making any profit on manufacturing them, giving them time on the manufacturing line, so they ceased to manufacture them. And, that's manifested itself in some pretty ugly ways. We've had growth of kind of unlicensed manufacturing through compounding pharmacies. We've had unavailability of important pharmaceuticals in the market. There's some 210 drugs on the ASHP drug shortage, drug unavailable list today. So as a market, we kind of asked for the problem we're getting. I think the response of Turing Pharmaceutical was, inexplicable, and he'll probably claw back a little bit, but he's not investing his money in R&D, and maybe in there lies where we should allow our money to flow. If companies have R&D risk, I think as a society, we want to invest in innovation in the United States. We want to be the leaders in healthcare and other industries, but his play was just financial. He paid $50 million for the license to the drug to do with it whatever he wanted, and we got to watch what he did with it.
Part of that problem also applies to the tax law. We allow advertising to be charged off as expenses in that. One other thing, a different topic, talking about the independent assessments, especially on areas concerning RSPMI. Right now, those are being done by doctors, I believe. And if we do the independent assessment, what's going to be the qualification level of the people that's going to be doing the assessments?
That's an excellent question. There may be some doctors doing assessment for RSPMI benefits, but the majority, from my understanding from DBHS, are done by the actual providers of RSPMI services. By far, the majority are not physicians, just as a point of clarification. You want licensed clinicians to perform these assessments. There are requirements for credentialing For long-term care assessments, there's requirements for credentialing for individuals that do assessments for people with intellectual and developmental disabilities. And there should be licensing requirements for people who perform basically psychiatric assessments. That's essentially what they are. Most states require a level of at least a licensed MSW, a licensed MA or MS in psychology. Some may allow an MED for counseling with supervision. Certainly all physicians, any licensed PhD. If the state finds that they have a shortage and decides to do this through the current model, then you might want to reconsider a lower benefit. And if that was the case that you wanted to do that, we would look for other states. But we would recommend that the licensing requirements be minimally in the social work area or the psychology area, the counseling area, obviously any physician.
So if I'm hearing you right, you're not really recommending a rollback in the qualifications to do that?
I would think that what we're recommending would be an increase in the qualifications, because my understanding now is that licensed professional counselors can do evaluations under the current RSPMI benefit.
Thank you. Thank you, Mr. Chair.
Senator Ervin, you are recognized for a question.
Thank you. Over here. Appreciate your report. Couple of things. First question was a follow-up on Representative Ferguson's questions on the federally qualified health centers. Because of their enhanced reimbursement rate that they get, they're in direct competition, but they're subsidized federally. And they get federal subsidies and grants and monies in addition to, but they're actually in competition with private providers who don't get those subsidies. So is there a way to restructure, if you did bring them into the medical home model, would there be a way to restructure that to where it would be a level playing field?
That's a good question, and one that we would certainly want to look at as we put together that particular component of the program. We recognize the unique structure and situation that the FQHCs are in receiving direct federal grants. On the flip side, we also recognize that they are obligated to treat anybody that comes in the door, regardless of ability to pay, even if they're completely uninsured. And so structurally, those two are meant to net out, and if in some cases they don't, perhaps different changes on any ancillary programs that wrap around that might be appropriate.
Thank you. Well, I think it's important just because looking at their finance and their mix of patient population and mix of, with the onset of the Medicaid expansion and private option, there are very few folks now that that don't have any kind of coverage. So that component has kind of shifted. So I think it's something that you just need to look at as far as, because their population is very clear that it's private insurance, it's Medicaid, Medicare, the whole, basically what any private provider would have as well. Self-pay, it's the same mix. So I just wanted to follow up. But my main question is, I really appreciate the reorganization, the restructuring, the different things that you put in on enhancing program integrity, particularly the need or the requirement right now to always get CMS approval versus the CMS notification. I think that's very key because that slows down a lot. My question is, from a budgetary standpoint, there's a lot of recommendations in here on restructuring, on program integrity, on really beefing up the Medicaid component within our agencies. What's the dollar amount of that? And what's the restructuring cost of that? What would that be? And could you find it within the current DHS budget, or would it have to be something in addition? And I think that extends to the OMIG, Office of OMIG as well. And so I kind of want to know what that number would be, because I feel like that's something that should happen as soon as we can possibly do it. I don't know if that is factored into waiting for an 1115 waiver negotiations to allow that with a global waiver, or how does that work to where, do you have to have money up front in order to do that? And if so, what would that dollar amount be in our state budget? Does that make sense?
Yes, it does, and it's a great question. First and foremost, it's clear to us that there's enough money in the budget with other contracts that you could absolutely shift over to reorganization. This was not a reorganization project. So, you know, we could help with that as we go further. But we absolutely have identified contracts that through indirect costs, renegotiations, and other areas, and those funds can be used to really begin that reorganization process, depending upon your vision, because it could go, whatever your vision is, the reorganization would depend on that. But Martha, I'd like you to address quickly the question on the contract savings. As far as the,
Yeah, I would like to hear from Martha, because I know she has a lot of valuable information, and there are several people sitting here that hasn't been able to share with us, but I feel like it's kind of one of those things where you have to, where can you trap those savings now? And is it through procurement? Is it through consolidation of efforts? Because I feel like we're inefficient in managing our contracts and communication with, you know, enrollees, with providers. There's huge inefficiencies there, and opportunities to consolidate services and opportunities to really create some efficiencies now. And where can we find that, and what does that look like financially? I know that there's also legislation that would probably have to occur with that too, but.
Right, there are a number of existing constraints, some of which would take some statutory changes in order to give the department the flexibility to change some of the contracts. There are a number of things that are already in progress that the department is considering. We looked at this only for the top 25 contracts, and what we identified was a number of different sources of improvement. So one, we acknowledged where the department was already planning to scale back a particular activity or contract, or where that work just came to a logical conclusion. That basically is about almost $19 million of things that will just naturally come to an end. And there we're looking at comparing the state spend portion on the contract. If we're comparing this fiscal year as a baseline and looking at a fiscal year 19 or a fiscal year 20, so that you had time to fully make those changes, we're comparing those 2 points in time to give you that annual savings. We believe there are some opportunities to renegotiate contracts where situations have changed, where there are other events that just, you know, what you contracted for a few years ago and what your needs are now may be different, where we believe the contract is out of sync with market price. So we applied our professional judgment, and we believe that's at least $4 million, could potentially be more, depending upon which contracts are impacted in that category. And again, it's that same savings methodology of comparing an annual spend a few years out when you've had time to make these changes to the current spend. We also looked at the small number of contracts that are a cost-plus contract, where you basically are saying, what's an acceptable overhead rate in a cost-plus contract? And there we were assuming some market judgment of what we felt was an appropriate rate. We looked at that in two categories. We looked at that for contracts that are between state agencies, because a number of states have put some legislation or at least policy in place suggesting that when one agency provides a service to another agency, perhaps there's a cap on what that overhead rate might be. The other is in the private sector. Do you just have sort of a sanity check there? Do you have something where that overhead rate would not pass your sanity check and you would want to negotiate harder with that vendor on capping that rate? We believe the savings there are relatively minor, a little over $1 million, might be as high as $2 million. If you applied this logic to all contracts, not just the top 25, you could get some bigger savings. The effort, of course, to make all these things happen this is a tremendous amount of renegotiation or reprocurement activity, and that's where we have to be very sensitive to the department's limited resources, that they don't exactly have a bunch of people standing around ready to write RFPs and to, you know, they don't have an army of lawyers ready to go renegotiate the contracts. So how fast you could achieve some of these savings is something that would have to be figured out in an implementation plan.
Okay. My last question is, and I appreciate that, so, because I feel like we have focused on all these other different things and kind of ignored our basics, our structure, and make sure that our structure is sound as we go forward, and we've just kind of gone in all these different directions. But my last question is, the focus on creating the community-based program that you're discussing, that requires, it seems to me through your entire report, a big rebalancing. And how would you do that and provide stability with the current situation, and then try to find that rebalancing and reshifting to more of a preventive primary care, community-based type of a healthcare model? It just seems like, is that a process of the negotiations with CMS, or how do you achieve that?
Well, I've actually been involved in that, so I've done it as a secretary. This department has the opportunity, because it's really high institutional focus, to make even small changes is going to make a big difference. You don't want to start too quick, but there's something that you need to really step back and say when you deal with the age-blind and disabled population. And I know you're going to be talking about the managed care versus primary care, patient-centered medical home. And, you know, it's the management of that. Do you want to go forward with having DHS manage 3 or 4 vendors that are going to have an incentive, a great incentive, to do the rebalancing? And they've done it in other states, and it's worked. Versus, do you want 100 contracts? One with every nursing home, one with every, you know, big provider of different behavioral health benefit and development disability, and manage a lot of contracts. And if you do that, your point is so well taken, you're going to have to really fix the organization and have it ready to meet the resources. Versus change the organization to really focus on a great contract management operation. And that's the first thing you would focus on there. That's why the decisions that you make are so important. So it has happened. Your neighbor in Tennessee has succeeded. 2008 legislation implemented 2010. All you need to do is look at that statute. What they have done in the community-based care in Tennessee continues to work. Texas, we mentioned. There are other states that we could also mention, and it works. But you also have to look at your levels of care. And here's the other thing, the waiver. So one of the things, you have seniors out there that are at risk for institutional care today, that may need some preventative type care, something in prevention. And your level of care says, unless you're nursing home level, you're not going to get what you need for services. If you're able to shift your levels of care, and CMS were to allow it, you do that in a waiver, that they're able to fund certain programs that seniors could use to save on the other end, which they've done in other states. That's all part of your rebalancing structure. So there's a lot of things there in that question. But at the end of the day, it's really I want to just end with the culture. And Richard has done this in states as well, and he may want to add. But it's a culture change. And when I said to the committee, I think one of the first meetings, on the 703 level of care that nursing home level of care, 703, look at that 703 in Arkansas. There is not one mention at all of community-based care. It's all about nursing home level of care. There's no incentive in the system, and there's no priority in that community-based structure. So first, it's changing the culture here, and then putting the resources to affect that change. And some of it is waiver negotiation.
Thank you, John. I think that one of the things that these types of graphs of data get overwhelming is the huge numbers. In point of fact, the progression that is in slide 45 in terms of long-term care is between 12 and 15% over the 5-year period of time. So on an annual basis, to get to the national average from where the state of Arkansas is in long-term care, you're looking at about 2.5 to 3% a year transition from nursing home level of care to home and community-based level of care. I'm not saying that's not a huge challenge. All I'm saying is I would measure that on an annual basis in terms of the need to develop new options in the community. You have some good strengths going for you in this state. One of the strengths, I think John's mentioned quite a few times, is your nursing nursing home industry, long-term care industry is highly knowledgeable and adaptable and business-oriented. So I think that the opportunity for them to evolve with different needs is going to be there. You've got the cap on the assisted living construction, which is a counterintuitive strength in the fact that you've used it so little, the opportunity to treat more people in a lower cost, sort of second tier level of care is there without you already exhausting that benefit in terms of your aggregate cost. You've got really strong AAAs that are out there that have provided you service in a variety of different ways, and perhaps their business model will have to change in the future. But you have that. And then you have a provider community that's been living on rates that haven't changed since 2008. So the opportunity, I think, to develop your infrastructure over this 5-year period of time has a lot going for it.
Thank you.
Representative Murdoch, you're recognized for a question. Hold on, I'm gonna push your button again.
I'm good. You good?
Oh, you're on? Okay, good, good, good.
Thank you, Chairman.
You're welcome.
Thanks, John. Good to see your
Thank
team here. Going back to the need for the independent or the independent assessors, going back to that. So in your research during the time you were here, did you find that our providers were making bad decisions in some of their assessments? What made you put that in your report? Just some of your findings on that.
That's an excellent question, and thank you. I think just structurally, from best practices, states don't deliver services to the serious and persistently mentally ill and seriously emotionally disturbed child and adolescent population without a clinical assessment on a standardized assessment tool that has been statistically validated and normed for the population within that state. So I think that that's just a best practice, regardless of whether you're paying fee-for-service or regardless of whether you're paying a managed care entity or regardless if you're paying an accountable care organization or a bundled payment or whatever. It's just good clinical practice.
So it's not necessarily from research and you say, hey, this is a problem, because some of your research that you got, that the group did, you found some issues that so it wasn't that per se.
Thank you for bringing that up. I think that one of the things that really triggered me was the distribution of the RSPMI benefit by numbers of people served and average cost. And you've got about 90,000 people total. That includes children, which are actually in the majority for a rehabilitation benefit, which is highly unusual for a state. Usually the state mental health rehabilitation option, the rehab option it is called, is majority adults. That may be a good thing in Arkansas. But you have about 41,000 RSPMI benefits. Now, RSPMI benefits are people with serious and persistent mental illness with what you would consider primary psychiatric diagnoses of schizophrenia, which is generally considered in today's day and age a lifelong condition. It's subject to recovery, and many people do. But it's like a lot of issues, it's potentially chronic in terms of life cycle. We saw 41,000 people of your total population served on a $300+ million benefit that were receiving less than $1,000 a year's worth of service. That's counterintuitive to the population that's targeted for this benefit. I'm not going to talk about the outliers that were generating perhaps $300,000 a year in costs. The outliers, I think, are for another issue. But in terms of whether or not this benefit is going to people with severe and persistent mental illness or kids with serious and emotional disturbance to a high degree of acuity is a really significant question when you see 41,000 out of a total population of 90 receiving less than $1,000 a year, or an average of $1,000 a year in the benefit itself.
So intuitively, you're suggesting that it probably is some effect on outcomes. What about the financial side of it, to savings? So do you assume in that same analysis that if we use this best practice that we're going to realize some savings from doing it that way?
Yes, I think when talking with Stephen in the projections, I think we estimated a 20% savings on their RSPMI benefit in the first year. We talked about a higher level of savings, but we thought 20% was consistent with what you would expect in general from shifting from a non-assessed this particular population to an assessed population, and then we just left it at that. We did not do the kind of research that would indicate whether or not there was inappropriate use or abuse of the benefit. That's been raised by some of the members individually of concerns about that, but our study did not include that type of an assessment.
Okay, last one, Chairman, if I may. Mr. Stevens, I know, John, that you were in New Hampshire, right? That's where you
Yes.
state that you were
Yes.
kind of involved in the Medicaid program and what they did. What are they doing now there? What's
They
the
actually have gone to full managed care since I've left.
Mhm.
They're moving the development disability and the long-term care populations into managed care, but they've done all population, their plan is all populations, all in managed care.
All right. Thank you, Chairman. Thank you, John.
Senator Elliott, you're recognized for a question.
Thank you, Mr. Chair. I'm asking a question from slide 14, and it has to do with the review process and the recommendation, the concern that our review process is very cumbersome. And I would just like your remarks on some notion of what other states are doing to be sure they don't have, I guess, microscopic and microcosmic management of this review process, as to give us some notion of how we might.
It's a great
deal with
question. I think the reason that this is in there is the number of committees and then the timeline that it takes. And what we've seen in other states is a more streamlined timeline. If you have 3 committees that you have to go through, it's almost, they're backed up, one day after time, so that you can, within a few days, you'll have either your approval, you go back and change, and if there's issues that you need, there's committees and rules that will say, we object to this rule because of X, Y, and Z, but then it's back within the next 30 days, and it's gone through the process, or it hasn't. And then the department has finality. What I was struck with was so many times talking to Director Seelig, and there would be things that I'd be saying, other states are already moving this direction. Well, we need to get, approval from this committee, and we need to get, and there were not a lot of resources that could put all that together. And so a streamlined more approach in having maybe it's the timeline, the number of committees, and also with regard to the federal government, it doesn't only apply to your state. And I stressed this earlier this morning, I'll stress it again. You're at the table with CMS, and the director and the governor, especially the governor. I've been there when the governor has sat right across from Secretary Thompson. If we are going to do these changes, we need help in making sure that we're not going to be told every single rule and every policy and everything has to be sent to the desk of a CMS individual and it's going to sit there for weeks and weeks and months. And that's what I'm afraid of, because that's what happens with CMS. I'm just being honest. So we've got to figure out a way that makes it a lot more streamlined. And they keep talking at the top of the federal government that we want to give you flexibility. The president has said that. But it doesn't happen when it gets to the lower levels. So your opportunity is to make it happen. And I think there's some good opportunity there. So It's a lot that goes into this, but the one example we shared in the appendix was the approval process for the state of Rhode Island, which is in their waiver.
Okay.
And if they want to do some simple plan changes, amendments, contract changes, they merely have to notify CMS. If they want to make more substantive changes, they have to notify them, and they have to have a 45-day turnaround approval, which is much different than 6 months or 9 months. And that's all in the contract that was negotiated. Other states would love to have that language in their waivers, and they don't.
Well, you got to the next question I was going to ask. The notion that about procurement, these similar kind of concerns with procurement, as well as the review process about rule changes. These are similar concerns, correct?
Absolutely.
That we're talking about. And so the question for me about that is, notwithstanding all of the committees and whatnot, if we were to not have all those committees for review, are there instances of states, and I'm sorry I haven't had a chance to read the report, are there instances of states, though, that have passed some kind of process that is broad enough, but yet streamlined enough there's accountability without going through several review processes from one committee to the next to the next?
That's a great question. And most recently, North Carolina on September 21st, their legislature, after several years of debate, voted to move the Medicaid program into full managed care. North Carolina was the bellwether for the PCMH model, just as a sidebar, and it was an excellent model, but people thought that it had not brought the savings that they needed in today's day and age. Its model's been around. But the point of the matter is, within that legislation, the House and the Senate agreed to create a joint legislative oversight committee for the state Medicaid program. And that one singular committee, a joint legislative oversight committee with equal representation from both bodies, appointed by the chief authorities in both bodies, we're going to go forward and basically manage the future of the Medicaid program under the state laws in relationship with the executive branch, of course, in North Carolina. In Washington, there's two committees, one in the House and one in the Senate. Washington's been involved with health reform for decades. The health home really originated with group health in Seattle, Washington, before this got to be a Medicaid issue, just good PCP practitioners. And those two committees have full authority in their bodies over the Medicaid portfolio and all ancillary services related to that. So they do have to go through both bodies, and that's the way they've chosen it there. But that, having been involved with that for 5 years, that can be a fairly expeditious process because they go on simultaneously on the legal level during a legislative session.
All right, thanks, Mr. Chair. Thank you.
Representative Hammer, you're recognized for a question.
Thank you, Mr. Chair. I want to ask you about the results of the scrubbing of the rolls. That do you have a dollar amount that translated into, or did you run any calculations on that?
No, because we are not assuming that any of it is fraud or individuals without further investigation are not subject to your eligibility requirements. But if you had to use just estimates, if you looked at it and you had the 20,000 individuals that could potentially be out of state, and you just look at the $495 a month carrier population on private option, you could put those numbers together. But we think that when you start investigating, there's going to be legitimate reasons for some of them, but there's going to be a handful you're going to find that didn't notify the state, and it's going to be significant savings. So, I mean, it's hard for us to estimate. We did not put any of those estimates in any of our savings estimates for you. We purposely stayed away from that, but we do recommend that your Medicaid Integrity, as well as your department, who now has that list, to start looking at that, Representative, and potentially report back and, what have they identified? Because there are savings in there. But
Well, John, on that score, excuse me, Representative Hammer, I just want to make sure I understand something from a conversation you and I had, because when I asked you, I was outraged, and I said, I want the best state in the country, and I want to do just what they're doing. And you told me, well, you already are. Nobody's doing anything about this. And so when you said, hey, I've got a recommendation in this binder today to put a new front end on things and put it out of DF&A, Arkansas could be the first state in the history of the United States to actually go and tackle these problems. Am I summarizing that about right? I just want to make sure that I'm in the ballpark.
Yeah, I mean, I did mention Florida. I want to give them credit on the front end, online. They were the first state to do this. Illinois then passed legislation. Texas has some aspect. They have different aspects of it, but it's not the truly front-end integrated, other than Florida. Florida is, that we're recommending. But yeah, you would be a leader nationally if you implemented the Enterprise Benefit Integrity Hub for private option, for expansion-related populations especially. Nobody that I'm aware of is doing it in the expansion population area that way.
Okay, and part of the reason I asked that question was if there's savings to be gathered, is there something, do we have to have a change from CMS in order to be able to address that issue as we're currently doing now, or because that's something we could do as a state expeditiously so we could capture those savings to implement some of the suggestions that you're offering?
It's a great question. Jason from our team has actually been in conversations with CMS about that very issue. They have a one-year redetermination rule, and he felt that there was a way around that rule, and I'll let him speak.
There are a number of areas where you would have to renegotiate elements of different agreements with CMS. Early indications are in our conversations with CMS that they would welcome that conversation. In the areas where we're not assured that CMS would be as open to conversation, we indicated that in our report. But in the core recommendation here around the front-end integrity, I don't think there would be any issue. But you do have to bounce off them and reset how certain processes are done.
And if I can add to that, the way the rule is structured today is redeterminations are done 1 year and no less than 1 year. And that's stated in the rule, the federal rule. What we're suggesting is we're not going to recommend that you seek a waiver of that rule. What we think you can do with this Enterprise Hub idea is run the data sources quarterly, monthly, however you want to do it, when it ends up being running efficiently, to just check. And once you have a hit, a flag, like what we had in the scrub, the flag then generates automatically a letter to the individual at that address. If it comes back undelivered, you then can notify that individual 30 days, notice for a hearing, or you're off the program, you're disenrolled. That is within the 1 year framework, and that is absolutely allowed, and I don't believe you need a waiver for that. In fact, states actually have done that in areas where, let's say, an individual, they get a tip, an anonymous tip that, hey, someone living in another state is getting Medicaid, and they're getting Medicaid services from your state. They could then search and send a letter out as long as they're notified that there's an issue, and they don't have to wait that 1 year for redetermination. But it's not automated, and they're not doing it up against an address and identity and an automated check that way.
Okay, and taking that, transitioning to a question about the medical home model. When we talk about managed care, which is a big part of what I see in the recommendation, how does managed care not compete against the medical home model? Because it seems like some of the things that were supposed to be achieved in the medical home model when it comes to education and other things, we're now asking managed care to do. So I'm wondering, do we need to drop the reimbursement rate to the medical home model if we're going to come in with the managed care, or can you help me understand how the two balance against each other?
If I understood your question correctly, Representative, the way the managed care companies, I think, assure people access their medical homes is to do community outreach. And we saw examples of that in Mississippi as well as Louisiana, where the state works with the MCOs in helping them access people in the community on the ground through different models. Some of those include MCO outreach, some of them include community outreach, some of that includes third-party outreach that might be part of the safety net infrastructure. In terms of the rates, in terms of the current PCMH, To answer the question on rates from a managed care perspective, on an individual basis, would be somewhat misleading because the rates are set in a managed care construction on an actuarial analysis by a certified actuary on all costs. And then depending on how the construction of the actuarial rate is being established, it could be established as a population level based on some measure of risk. Some states historically have had 3 levels: low level, mid level, and high level. States have gotten, and so has the actuarial industry in terms of dealing with the Medicaid population, more sophisticated and go into what's called rate cells, which is certainly something that we've recommended in the details of our weeds, if you will, recommendations about state managed care contracting. If the rate was considered for any service to be needing an adjustment, it would get processed through the actuarial construction.
So would we lower the reimbursement rate to the medical home model that is supposed to be built in for savings by, reducing returns to?
If there is an enhanced rate for a particular mechanism of management, that would be taken into, and that was transferred from the current model of fee-for-service, in this case PCMH, it could be anything, and then translated through the actuarial construction. If you follow the rate through, yeah, more than likely there'd be a reduction in the rate.
All right, and does lockout, the term you used in your report, does lockout at the end of the day turn into uncompensated care, and how is that enforceable if you lock somebody out of the system?
Yeah, there's no question lockout could result in more uncompensated care.
What about other states that have implemented the lockout approach, and have you tracked how that has affected their uncompensated care, as a benchmark to what it was before? Because I think if we're going to, I like the concept, but is it enforceable is the question, and at what cost is it going to be, enforceable in uncompensated care we got a budget for?
We haven't benchmarked that, but that is a great question, and we're going to. I do want to make sure we get that information for you. It's really Indiana would be the one state that would have the best experience because they've done it the longest. But what I have heard when I spoke to the Indiana state is that it really hasn't had as many individuals locked out as you would think because they're complying with their power account. In this state, the recommendation that we've given, we're hoping or hopeful that you would have compliance with the wellness and membership agreement and other incentivized areas where you wouldn't have as much an impact on uncompensated care. But it's going to be some impact.
Okay, last question on system integrator that you mentioned a while ago. We had a report the other day in another committee about that very subject, about the need for a system integrator. That system integrator would be the one that would help get all the silos to communicate with each other. They'd break down those barriers that are currently in place. Is the system integrator going to be a standalone entity, or would it be somebody in your proposal, if it's in there, does that become part of the DHS structure, or is that going to be handled through a separate contract, or what's the most efficient way to handle that?
Whenever you procure in the marketplace, you need to be cognizant of what skills are available and how the vendors package those skills together. So probably to find a system integrator, you're going to have a company who specializes in doing these large technology projects in this particular Medicaid space. And so you're probably going to wind up with that skill set coming from one vendor that perhaps is different from some of the other vendors that you need to contract for other services.
But that would be covered by whoever we would hire to write the RFQ or the RFP for that, so that we make sure we get the right integrator. So, I mean, it's really critical that you get the one in order to make sure you get the proper of the other. Is that correct?
Right. As we said in the report, it's very important that you get your requirements right. And so you figure out what structure you want, you figure out what you want this vendor to do, and then you go hire somebody and hold their feet to the fire that they have to do exactly what you ask them.
Thank you. Thank you, Mr. Chair.
Senator Sanders, you're recognized for a question.
Yeah, thank you, Mr. Chair. Stephen, John, Richard, thank you and team, thank you for all the hard work and hours that you put in and years of your life that you took off, I'm sure. It's very comprehensive, and And I think there are a lot of great recommendations in here. With regard to looking at those who are over 100% of FPL and looking at pulling them out, this would be sort of your out of the box approach. I wonder if we shouldn't take a look at removing all able-bodied working adults from Title 19, making it part of a waiver negotiation with CMS. I think what we've shown and what we've seen is when you look at the cost on the private option and you look at what amount of RAP coverages we've had to cover, I mean, it's less than 1%. And I mean, couldn't we make a case that the majority of able-bodied working adults really need coverage? They don't need all the enhanced benefits that are afforded to individuals under Title 19. And couldn't that be part of a negotiation as well?
Senator, that's a great question. It's part of the idea that we've raised, because what you're talking about here is, again, you are not, from what we heard, what we've seen, you're not going to get that from this administration, because it requires a waiver of the essential health benefits. That's what this comes down to.
Well, on that particular item, you wouldn't be. I mean, basically what you would be saying is that you would put able-bodied working adults under the same sort of requirements,
In the marketplace.
in the marketplace. And so, therefore, you would differentiate, which you have done, between the age of the blind, the disabled, the medically frail, which is important, but then sort of bifurcating the system. I mean, it wouldn't essentially require waiving the essential benefits. What it would require under an 1115 would be waiving that and say, for purposes of coverage, able-bodied working adults traditionally covered under Title 19 would receive their coverage under some other mechanism. So it would have to be very specific in the language. And I'm wondering, again, it would, and I think maybe the experience, if our experience had been different, if we had seen a large number of individuals under 100% of FPL needing and receiving a significant number of RAP benefits. But when you're looking at this, I mean, we're talking about less than 1%. I mean, this is, we have EPTSD that we would have to deal with 18 and 19-year-olds. And that may be, that may be something that we'd have to provide. But it seems to me that would afford, more, a more straightforward manner to handle coverage for these individuals.
It's very much in line with what the out-of-the-box recommendation is.
Move it down.
It's part, you'd have to negotiate, but my concern would be that removing them from Title 19 may be an issue at CMS.
We'll have to get together and read the art of the deal together, I suppose.
Yeah.
Right? So, I appreciate it. Thank you. Thank you. And I think it's something that we need to discuss moving forward.
Senator Cooper, you're recognized for a question.
Thank you, Mr. Chair. In your slides, you talked about the 40% that has zero income. Did you drill down into that any deeper as to why that might be?
No, we didn't, and I really wanted to, but they had a lot of issues at the department on the EEF system and the eligibility, and it was very difficult to get that data, especially to get it to FPL level. But what I did was I asked Director Seelig if he had done this in the past, because it takes time and resources.
Mm-hmm.
And his answer was yes. He sent me an email, showed me the October data. It was all there. They had already spent the time on it. And his statement to us was he had no reason to believe it has changed anywhat with the most recent. We could drill down, but that's a very labor-intensive activity.
Is that in line with what you may have seen in other states?
Yes, yes. And it may be that, and Stephen, you may have something different, but it may be that the number of those that are between 100 and 138 was on the lower end here in Arkansas, and much higher end on the folks that are not working. But your unemployment numbers have gone down nationally. So there could be a shift and it could be a change if we look at it today.
If you've seen it in other states, have you drilled down into it in another state?
No.
Okay.
Again, it's very difficult because you're dealing with taking from the eligibility system what they have submitted for their FPL and not just the data. And the FPL is within the state system is difficult to get at because you're dealing with family size. Now you have to go to another data source on what's the family size. It gets very complex.
Okay.
Do you have anything to add?
On your circumstances that you found in Texas and Tennessee and the surrounding states, to say how effective something might be in Arkansas probably also has a bearing on the similarity of demographics, population, and other things. And the thing that concerns me about that is Tennessee and Texas may not be demographically similar to what we are.
If that's a question, I really
Yeah, it is.
appreciate the question.
Are we?
Um,
And how do you relate that? And are you confident in that?
Stephen.
No two states are exactly the same.
Sure.
From our earlier task force updates, you heard us alluding to the Medicaid experience in lots of states throughout the country, and we heard very clearly from y'all that you did not necessarily think a lot of those states were good analogies to draw from for the Arkansas experience. And so today, for instance, you've heard us talking a lot about your immediate neighbors as potential examples. In looking particularly at some of the cost projections, we did draw our assumptions from some of your neighbor states for the managed care projections, for instance, that came from the Louisiana experience. Are their demographics exactly the same? No, but they're more similar than most other states. And so as far as these things go, we feel like the conclusions or the assumptions that we drew from those states are reasonable and probably as good as we can do under the circumstances.
Okay. On the organization chart that you showed, I guess if I could summarize what you're trying to present there is the need to enhance basic quality control across the organization. And the thing that's kind of struck me for some time is it seems like we are light in government on quality control as you would find in private industry. In private industry, you normally have a quality control group that is outside the reporting structure that goes skip level. And is that something that's going to be greatly enhanced? And also in connection with that is, should there be an enhancement of something just called quality control organization within the OIG that's not looking at particularly violations of law, but efficiencies within the organization?
We tried to make a number of points on the organization. We strongly believe we have to emphasize more collaboration, that we've got to have the parts of the organization pull together to serve the populations, to work across all the services, to be able to coordinate in a much more integrated fashion, and that there are economies of scale essentially of doing that. So where you have one group doing data analytics and another group is also doing data analytics, is there an economy of scale if you could put those groups together and do it in a more holistic way? So I think that's important. The vendor oversight, depending upon the path that the state chooses, you may wind up with larger contracts. You may wind up with needing to go head-to-head with some even bigger dollar amounts at stake, and just make sure that you're doing a really good job on that. We certainly talked about the integrity side. We absolutely believe that the technology support as well as the organizational support to manage the integrity of the program needs additional attention, whether that's an independent function, whether that's integrated within the department. we could debate the role of both in terms of understanding the data that you have, as well as having a separate objective look at it. But we do believe that function that you alluded to absolutely needs to be beefed up.
Senator Cooper, I want to just also address efficiency, was your question. You mentioned the word efficiency. There is, to my knowledge, and maybe I missed this or we missed this, but I didn't get the sense, or I don't think any of us got the sense that there's a real good quality control component on efficiency. So, for example, a group that is looking at improvement throughout the entire department at all times, auditing functions, some of their contracting, real time, and continuously trying to, almost like a CQI function, continuous quality improvement. So that would be something that we've built in here, and I think it's really important. When you talk about Medicaid Inspector General, you already have a statute that you passed a year ago, I think it was a year or 2 years ago, shifting OMEG to a separate department, which some states have done. And the statute is broad. The statute allows them to look at waste, fraud, and abuse. And through that collaboration with the department, you could get a lot of synergies and efficiencies there. And I think OMEG could be doing a lot more than it is today with the right tools and the right individuals to look at and enhance quality function as well, so that the department is constantly working to meet the needs of the taxpayer. So there's a lot of opportunity you have there.
Thank you, I appreciate that. Thank you, Mr. Chair.
Senator King, you're recognized for a question.
Thank you, Mr. Chairman. You know, this eligibility issue and trying to find out the truth and the facts about this has been something I've worked on for a couple years. I mean, it looks like you've got an equal problem in traditional Medicaid with some of these red flags as you do the private option. I was wondering, when you see these addresses that people are signing up for the private option and then no Arkansas address, what's DHS doing when they're confirming these people?
They don't have an automated system to check addresses.
And we were promised by Director Seelig and Governor Beebe and the architects this great verification system, and we don't even have any verification system, it seems like.
One of the issues we didn't talk about was long-term care asset verification. They recognize they're out of compliance and need to have that, and they're moving in that direction. So there's a number of areas where they're attempting to improve, but what we're talking about, though, I want to make it clear. I know Representative Collins mentioned this earlier, that there aren't many states that are really looking at this whole automated address verification system. And the reason why I think it's very important for you, and why we say DFA, think about the return mail that you're getting in every single department. The dollars that you're spending every single day of return mail that could be used to help that individual that needs care on the wait list. You are wasting taxpayer dollars every day. And so here's the other issue. If you go to managed care, and you begin to pay a per member per month fee to another company, including the carriers, it's going to even be a more pronounced issue, and you're going to want that in place. Today, though, in the Medicaid program, it's a fee-for-service, basically. If you move in patient-centered medical home to a bundled payment system, it will become an issue. But traditionally in the Medicaid program, you're in a fee-for-service, so it's really the claim is going to be what generate the cost. And so it's more pronounced, though, when you're paying a per member per month fee to have this system in place. But I hope I've addressed your questions, Senator, but there is no real-time automated address verification.
Yeah, I understand that. And you know, the people that, as I've said before, when you set up a one-year check, I mean, I know what's happening in the real world. People sign up for it, and then when they get a job making more money, and then they get this notice, they just go quit their job and re-sign back up. But what we're seeing up here in border counties is that people sign up for it here, and then they move to Missouri, and they continue to be on Arkansas health care, paid by Arkansas taxpayers. And I've brought this issue up in committee meetings, and the other issue is about when we're getting this list from DHS that says these are the enrollees by county, I mean, there's, 1,300 people in California that have an address from your, so, I mean, it's just like, we're not getting truthful information from them. But let me ask you this, Ray, you've done work in Illinois with this same system and doing that with some verification, is that correct?
Yes.
And then what was your response back after you came out with that? I mean, what did you find? Were you discredited out of that? Did you?
No. No, Illinois took a different approach. Illinois did not decide to, they did they're working still on it. It's taking a long time. But they decided to put millions of dollars into hiring employees to basically question folks that come in and do all the extra work and legwork, and it was more hiring FTEs. Now, Illinois is a state that likes to expand their state employees. And that's one thing that they did, instead of going into outsource and doing it on an automated fashion. And so, but Illinois is definitely an example. There's statutory language I can share with the committee. It was called the, I forget the name of the act, but it's a complete, they really focused on one issue. They wrote an act, it's about 10 or so pages, and they put this program in place. It is working, but what happened was they found that there was a lot of individuals that didn't have the right information when they came to the office. And what the workers would do is override a lot of it and just let them come on. And so what they did is they saved a lot of money on cost avoidance because it took some extra time for them to get the paperwork. But again, there are rules that are required here. There are rules that should be enforced for your program. And eligibility should be taken seriously. And so if you start doing that, you will see cost avoidance savings, you will see other savings.
Well, we were promised eligibility was going to be when this originally got passed, but the reason DHS and these other people, and I think even some legislators have kept this covered up is because our vote margins are so thin. If legislators had been knowing the accurate information about how bad this system is, the cost overruns, they're not telling legislators about these millions and millions of dollars spent for nothing, and then turn around and we're going to spend $200 million more, then this program wouldn't have got reauthorized. I mean, this is not your issue. This is a separate issue that we've been trying to find out the truth and the facts about the eligibility and the accuracy of the enrollees. But the main point is, in your work that you did in Illinois, you were not discredited by using the same process you did to find out this information. You found out your information up there was pretty accurate, I would assume, right?
Yes, I mean, in Illinois, I helped the legislature in drafting the legislation. The implementation was done after I left. And so I can share with you and I can get some information for you on how, I believe it's a SMART Act, and I can get some information on how it was implemented. I don't feel comfortable mentioning exactly how it was implemented, but I do know that they hired, I believe in the beginning, Maximus, who came in with a lot of state employees, and then the state ended up taking over and Maximus left because there was some issue between state employees and outsource vendor, and there were a lot of issues. And we could get some more information for the committee on that.
Well,
But
I filed a bill this last session based on a
Senator, we're gonna have to move to another person. Push your button. You can go back in the queue, but
sure.
we've got too many in line to keep going with more. Representative Gray, you're recognized for a question.
Thank you, Mr. Chair. I think this is to Mr. Kellogg. You had said earlier, kind of going back to the independent assessments, that we didn't have enough qualified professionals to assess independently, and that's what I thought I heard you say. But I will attest to that as well, just from being in the medical profession, that we do have a shortage of healthcare professionals. And so one of my concerns is, if we go to more of an independent assessment model, we have to use more licensed therapists or licensed counselors, whatever, outside of the setting that they're currently getting it done in. Has there been any type of assessment done to see if we have enough healthcare professionals in the state to even do this? We'll answer that one first.
The answer to that question specifically is no, we have not.
Okay, thank you. And I know, like, maybe you can help me understand it better. CHMS, I know, like, they have an assessment tool for admittance to their facilities. Then they have, like, a medical director that approves it. Then they have to have a PCP referral who approves it. And then it goes to AFMC, I believe, for an additional layer. So there's, like, 4 assessments done already. So I'm trying to figure out how an independent assessment would how that would actually save any money, because we already have all these layers.
That is an excellent question, and I just was at CHMS yesterday. I was not including CHMS in relationship to the comments about
Right.
the RSPMI benefit. In relationship to the assessment process at CHMS, I have to admit that I was confused after meeting with Ms. Denton. She was on a plane to Chicago 20 minutes after we finished, so we didn't have enough time. I specifically went over there to try to get an idea of what the CHMS model was and where mental health, if it fit in at all. And I'm still not clear on that, but I did not see a great mental health emphasis in that program. What I did see was that apparently there was legislation passed that did a good thing, which was basically connect OTs, occupational, physical, and speech therapy under a singular benefit for the targeted population. Other than that, that's about, I know there's a lot of day programming over there. I was a little bit unclear on what the day programming was in relationship to the specific, what would be coded billing for OTPT and speech. I did not know what the relationship was, so I can't really comment on that, but that's a question that remains. In terms of the multiplicity of assessments that end up at, you know, in this case, perhaps at AFMC, I'm not familiar with that because it was not part of the three major constructions of assessment that we did look at in detail, which was long-term care, DD, and the mental health benefit.
Okay, and that's, I wasn't sure if the other areas had assessments as many layers as like what CHMS has, which I'm more familiar with. And then, I guess finally, Mr. Chair, it's my understanding that these assessments are part of the Affordable Care Act, this independent or universal, it's not part of
No.
the Affordable Care Act?
No, assessments have been required in B and C waivers for quite a while.
Or we're not operating within the law right now?
No, you are in DD and in the mental health benefit. I think you're fine. I think the issue that needs to be determined in this state is the continued assessment of people that are in hospitals for home and community-based or nursing facility at level of need in areas where there could be independent assessors other than the qualified, excellent nursing home staff. That I do think is a question that you do need to look at going forward in terms of compliance with CMS requirements.
Okay, thank you. And where, did you take any of the suggestions from the mental health professionals or I didn't see many in here, or from the nursing home? I know they spend a tremendous deal of time preparing and looking for ways to save money. Are there many of those incorporated in here? And thank you.
I think if you look at the nursing home, I think they brought up a great model when they testified on the value-based purchasing. So yes, that's included within that patient-centered medical home model. And I absolutely would include them at the table. They have some great ideas. And they actually said to us that they were willing to embrace more of the home and community-based structure and be part of rebalancing. So if you move in that direction, I would recommend that they absolutely be a major player, part of the table, to work on whatever that payment structure is.
Senator Chesterfield, you're recognized for a question.
Richard
Oh,
had
I'm
one
sorry.
further.
I want to respond to the mental health question. We did look at the recommendations. There were excellent recommendations for the current system. However, we did make a determination, for good or bad, for today's meeting, that the whole entire RSPMI benefit really needs to be rewritten. You really need to move to evidence-based practice. You need to simplify the number of coded services that are in there. Other states have done this. You really need to look at evidence-based practice for children. It's simply not there.
Senator Chesterfield, you're recognized.
Thank you, Mr. Chair. Let's hope mine's a great question, too.
You always have great questions.
Oh, yeah, right, John. I know the definition for medically frail. Could you tell me the definition for able-bodied?
It would, I'm not sure there is a definition out there that's standardized or used. It is used to mean individuals that are capable of working, that are usually within that population age category of 19 to 64. And they're the ones that CMS has indicated through the expansion populations targeted towards.
Okay, well, and I'm not being facetious when I ask that question, because there are individuals who walk around every day who look able-bodied and are not. And so I just needed to know if there was some definition, since we have defined everything else.
Non-SSI, non-disabled, determined disabled.
Now, moving on to another not-so-great question. You're saying that that approximately 100,000 people have zero income. Is that about right?
Again, that's what the department had given us back from October of last year when they looked at it. So, yes, some of those could be individuals that have had employment that through some, unforeseen circumstances no longer working right now, but in a temporary basis. And we don't know without really digging into the, size of family payment, circumstances, individualized. I mean, that would be difficult.
As we look at the demographics of our information, is there a particular area of the state that seems to have a more acute problem as far as income is concerned?
I don't know the answer to that. I know we looked at the just unemployment rate from the Labor Department statistics. We could look at that. I know when we were in the regions that we went in, we targeted regions where we were told were real low income in terms of the socioeconomic status, and we were able to visit with people in those areas near the Delta and in the Pine Bluff area, but we could get that information for you.
And the reason I say that is because we do have employment deserts in this state. And when you're talking about individuals with zero income, people tend to think these are people who are not trying. They are obviously lazy, or they would be making some money. And that seems to be the stereotype that we invest in those individuals. And there are areas where there are no jobs. And so it would seem to me that that would be a contributing factor to the zero income. And I think it is worth our while to look at the totality of this state and those individuals that we're serving to see whether or not they are being deliberate in not wanting work, or the circumstances of where they are dictates whether or not work is available. And I'm not making excuses for folks that don't work. I've worked since I was 7 or 8 years old. But I do know that there are places where if there are no jobs, I can't get a job. And so I think we've got to look at that as well. And perhaps somewhere in your research, we can perhaps drill down just a little bit more deeply so that we don't give the impression that 100,000 folks in this state just don't want to work. And I think that's something that we got to do.
I appreciate the question, Senator, and we've noted it. And this is further analysis that we would definitely want to do. And it requires a lot of independent analysis. But I think that some of your Department of Workforce, and there might be some other areas where they've already done some of this analysis. So let us check and see what we can find out for you.
And you have checked across the silos. You have looked at the TANF numbers and all of this. And I'm wondering, in looking at TANF, can we cross-section and find out if these same people are saying they're not working? And I think that it would be worth our while to look at those two entities to see whether or not we're really getting the best information about whether or not folks are at zero income.
It's a great question. If
Mark it down.
If I know,
I got a great question. Okay.
I think that what I would like to take from that question is you also have unemployment data information. You have TANF. You have other data. And I asked a while ago Deputy White to work with me on this issue, and he is putting some stuff together, or he sent me a few informational emails to take who in your TANF population is also on private option, who in your unemployment population is also receiving benefits is in your private option. And I've noted that, and that's something we can absolutely do.
Right. Thank you. That was where I was going, because I'm hard pressed to believe that 100,000 folks just don't have any income. But if they don't, why don't they? But if they do, and we can go to other sources and verify one way or the other, I think we have a responsibility to do so. this does not include our children, right? The numbers don't include the kids at all?
No, they don't.
They don't include our kids A and B, and that would be helpful to me. Thank you so much. It's always good to see you guys, and we
Thank you, Senator.
appreciate that. I did read the report.
And I hope.
2.5 hours of it.
There was also a glossary in there, too.
And I used it religiously. Thank you, Mr. Chair, and thank you, gentlemen, for taking my question, and lady.
Representative Boyd, you recognize for a question.
Thank you, Mr. Chair. Maybe you've noticed it's been a long day, so maybe you've answered this somewhere through and I've just missed it, but if not, even if you have, I want to hear what you have to say. This is not a pharmacy-related question. There's a quote on page 4 of the slideshow. Many in the private option are not working. 40% have annual income of 0. I'm just wondering if you were able to dig down into that and see, are there like a lot of students? Is it like 39% of those are students, or is it really like 5% of those are students? Is there any more detail than just 40% are not working? And that's all.
Thank you for the question. It's a great question. We did receive that question, and our answer is we just took what the department had given us, and they had done their own analysis. That type of analysis, Representative, takes a lot of time, effort, and resources. From this point forward, we'll figure out, we'll work with the department and see what it's going to take to get you more information there. When you start comparing them, how many are students, what age they are, what's the family size, are they married, all those different components, it's all taking that from the eligibility system and being able to match it with other databases. It takes time. It's a lot of analysis, but we'll figure out what we can do for you.
Well, I want to be a little bit careful. Again, so before we run up, I mean, Representative Gray mentioned earlier today that there's a limit to how many hours, and I want to make sure now we're moving from a gathering information for the sake of information's sake, right? And we're moving more into assessing recommendations. And I think we're all very, very interested in employment in Arkansas and who's employed and why and what kind of education. So those are wonderful, wonderful questions. But before you spend a lot of money, I'd like to understand how it intersects with, yes, this is a good recommendation, no, this is a bad recommendation. So I just would put that out there for any of the extra work that we're going to be doing. Obviously, cursory top line, but those deep dives that get really expensive, I just want to be careful with those.
And how I'll answer that is if it ever gets to a point where I think it's going to be very detailed analysis, I would let the chairs know immediately. But I think that Representative Boyd's question is going to require some detailed analysis. And based on my discussions with Director Seelig, which is the reason why we relied on what Director Seelig's folks had already done and gave us from analysis back in October. But we'll continue to report back to you on that.
Okay. And again, I don't want to keep beating this horse, except to say, one of the things we're going to find in general is our charter is, a set of healthcare recommendations which you've given us, but healthcare touches everything. It touches education, it touches work, it touches taxes, it touches free markets versus non-free markets. It touches all kinds of things, and we can find ourselves scrolling off into other issues which are very, very important for state government, but aren't necessarily questions that are going to determine, yes, we want to do managed care, or no, we don't want to do managed care. And I just want to make sure that the extra work that you guys are going to be doing is focused on helping to resolve those issues and questions and challenges. And there are going to be some other things for state government to tackle that aren't necessarily your challenges to tackle. That's it. Representative Farrar, you're recognized for a question.
It's been so long, I about forgot my question. Thank y'all for coming out today. I appreciate all your work. If you go to slide 55, and I know what DRG, the payment system is, methodology for Medicare, and I see some other states are going that way, and you put it in your proposal. Can you kind of give me some examples of what other states are doing and how it's working there, and if it's a way that we want to go? And also, and I'll run two questions in the same time, you said in your presentation that Children's Hospital is the APR DRG. Could you explain that to me also? Because it's a Medicaid and not Medicare, and how's that
I'm
sound?
going to let Bob Chin answer that, but what I said is Children's Hospital is willing to entertain the discussion of moving to an APR-DRG system, and I'll let Bob explain that.
Okay, thank you.
Much of what we found in the industry and experts in the field, if you will, all really recommend the APR-PRG, which is an all-payer, all-population model for DRG application. It's a software developed by 3M, as opposed to the Medicare DRG, which was sort of the original grandfather, if you will, of the DRG model, which has been around for about 3 decades or so. So our recommendation would be to apply an APR DRG model. It offers a host of advantages compared to, say, the other DRG models, in that it was designed for the full demographics, younger, older, and so forth. And it has also more layers of severity regarding each of the different cases and diagnostic groups, so that you end up with a more refined way of applying what the pricing ought to be based on a particular patient's type of case as well as how severe it is. So that's what we're pushing for. We had done some very quick analysis. You know, we've all been under the gun. And in order to do it quickly, we did apply the Medicare one just so that we can get a sense as to how well the current claim system, the claims that have been received by the state, how well does it actually group? And for the most part, the bulk of the hospital inpatient claims grouped at a very, very high level. So that was a really good sign. We wanted to make sure that if there were any concerns we had structurally about how providers are coding, that we would sort of get a sense of that. But as we kind of expected, Arkansas Children's did not group very well, probably because the DRG model was not compatible with the case mix that they had. But we expect that the APR-DRG model would work quite a bit better. So that's kind of what is part of our recommendation going forward in terms of the next major phase of actually understanding what kind of impact we could have and applying the best methodology.
As right now, though, there is no other states doing this.
Oh, no. Quite a few. In fact, I would say that the bulk of the DRGs, in fact, all the red states, red just in color, not in ideology.
Right, I understand. Okay, so tell me how those states, well, actually, tell me how those states are working out with the DRG, with the Medicaid system.
So you can see that many of them are using APR-DRG. The light blue ones are MSDRG, and I would predict that in the next 5+ years, they'll probably all migrate toward APR-DRG, because I just think that it's a more refined model for commercial or a Medicaid population with a wider population span.
Okay, is the APRG as complicated as the regular DRG for the Medicare?
It's more complicated because it is more refined, so you kind of have to put in more effort.
So documentation is basically...
Yes, but it also allows you to narrow the band of what the payment is appropriate for that particular case. And I believe that's part of the reason why Children's themselves had said that that's really the appropriate model for them, which I was pleased to hear. Instead of saying, you know, we don't believe in DRG at all, which was not their case at all.
Okay, thank you.
Yep.
Okay, we've got just a couple more questions, and just as a reminder to everybody, we're going to be back on the 20th of October. So all of the task force members will have an opportunity to study in a lot more detail the proposals, formulate additional questions. Anyone else, folks that are providers or other groups, will also have a chance, obviously, to study the recommendations and the assessments and the findings. And what I would ask is, if you send to us, send it to Phil or me, and we'll, you know, address, you know, questions, concerns. But what I want to focus those on is with regard to the recommendation. So, you know, if somebody says, gosh, on page 58, they're recommending that you guys do this to my group, and it's based on these 3 assumptions or facts, and here's why I think those facts are all wrong. You know, give us that information so that we can get that to the Stevens group. They can incorporate it. They can understand, hey, we missed this. We didn't look under the right places to learn what we should have learned. And so, you know, we've made fallacious recommendation because we missed all this information. And then they can come back and tell us that. Or they can say, well, when we looked, you know, we saw this, you know, here's a counterpoint to that. Here's how we resolve the counterpoint. You know, we still stand strong behind our recommendation, or we would adjust our recommendation or whatever. So where I'm headed with this is, over the next, you know, couple weeks in particular, we're going to have an opportunity to play catch ball with, you know, a lot of the things that they've laid out, and which all of us are seeing, you know, really in depth for the first time today, so that, you know, coming out of the meeting on the 20th, you know, we're going to have, you know, a real sense of common ground. Doesn't mean we're all going to be happy with kind of what the landscape is, so that the task force can feel comfortable that we're operating with, you know, on terra firma, if you will, you know, as we make these decisions in the coming weeks. So with that, Senator Sanders, you're recognized for a question.
Chair, a couple things. With respect to, there's a strong commitment in here to PI, and you see a strong commitment to transparency in here as well. I think one of the things that we've obviously spent countless hours as a legislative body and in multiple committees dealing with is the enormous IT challenges that the state has been presented with, be it, you know, managing different pieces and components of eligibility verification system. I know we have, you know, we've worked really hard with the Medicaid Inspector General's office to give them the analytical tools. You know, we have the Optum contract that they utilize. And they're looking at the, you know, you referenced the APD right now, looking at more enhanced analytics. There's a lot of I mean, correct me if I'm wrong here. I mean, there's a lot of customization beyond those things, beyond dealing with an APCD, all payer claims database, or PI. When you're talking about the level of policy intricacy and determinations of certain pieces and parts, who will be eligible for coverage, under what terms, and I wonder, Stephen, maybe you can help out on this. Have you looked at sort of a schematic in what the IT backbone would look like on this? Because we've had a lot of discussions and debates about, you know, are we going to utilize the FFM? Are we going to go with the state customized approach on the exchange? You have a significant amount of customization that would be required under the SHOP exchange. What does that look like? I mean, and how is the interaction going to work? Because, you know, I think when people hear, you know, we need to invest new resources in program integrity, PI, OMIG. I mean, the good news is, as we all know, CMS reimburses at a 90-10 match on that. So, I mean, it's a minimal investment on part of the state. When you look at sort of dragging and creating a broader eligibility hub and locating some parts and pieces at DFNA, I mean, there are some limitations in terms of federal law, in terms of privacy on taxpayer information. So there's sort of a complicated rubric of funding sources, IT structure, and really, we really need to have a good idea of the amount of customization moving forward. And have you given thought to that? Have you drawn out anything, any type of schematics? We've looked at other states that do this. You know, you've referenced Texas. We've heard, you know, we've been to California. We've seen all those different things. How much brain power and time and effort have you put in trying to sort of draw out to give us a good understanding of what's going to be required of us?
So we have not looked at a lot of the IT stuff from a technical side, from like a technical architecture side, just because that's frankly out of scope from what we were doing. We looked at a lot of that more from the contractual and business process side. Based on my experience in other states and what we have seen from the Arkansas DHS IT infrastructure, it's not unlike the circumstances faced by other states in terms of having, as you noted, lots of complex systems with lots of requirements and drivers that are not necessarily all pushing or pulling in the same direction.
Yeah, we have not done a good job. And you're talking about looking at workforce services, looking at all these different pieces and parts in the TANF population. I mean, ideally, and I think what you're arguing for in sort of a conceptual model is, you know, one hub, one place, one point of emphasis. Now, we all know that, you know, conceptual and operational are sometimes as far as the east is from the west. And I think as we move forward, and again, I mean, I think when you look at the scope and everything that you've done out of scope, I think you guys get a pretty good understanding of why the McKinsey contract got so big, right? So, I mean, you know, we just want to do more and more and more. I do think it would be worth our while if we look at that IT piece, because at the end of the day, implementing policy requires a fundamental structural backbone in order to do it. Because we've sat through numerous meetings of saying, well, we want to do this, 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 and this, this. Well, why can't we do it? Well, I mean, there's usually an IT challenge. We haven't demonstrated an ability to manage IT very well. So I think that's something that we need to look at, particularly within the context of utilization of the FFM, utilization of eligibility verification, tying in, do we pursue an acuity model long-term where we're managing and looking at income in real time? These are huge, huge questions that carry with it substantial budgetary considerations for us as we're going to start budget hearings very soon. And we're going to have to know if we're going to be able to plan for that and what APDs we need to submit to CMS in order to get there. And so I think that's probably an offline conversation that the chair needs to have, the chairs need to have with you, but I think it's something that we need to look at as we sort of begin to hone in on what the end game looks like.
Your statement in question could essentially be seen as amounting to a restatement of the necessity for a strong systems integration function. I mean, that is what's historically been missing, caused a lot of the problems here. In different ways, it's a big, complex story. We're not going to take the time here. You've already heard it. But the problems that have been caused and engendered before by the lack of a strong systems integrator are not going away. That's why that is such a fundamental requirement for moving forward successfully. And you've articulated there with your question as well as anything.
I'd like to add there's an A87 waiver opportunity at 9010 that you mentioned, funding to enhance what you already have approval for. And I know that there's discussion of an RFP possibly going out and on the enterprise fraud pattern technology and the analytics that OMIG
And we have some funding for that currently.
And the federal government has approved it, but I believe the federal government has said, come back to us with the budget. But you have a state law that says, I think it has to be 80% or more funding from the federal side. So that shouldn't be an issue. But what could be an issue is the A87 requirement of the funding does have an ending date. And you want to get in that door and get that approval to get that 9010 funding, amend your PAPD, and we can assist in that, but you want to amend that so that you can at least get in the door now to get approval from CMS of the design and of the methodology today, so that when they say someday down the road or new administration no longer going to do 9010, you want to make sure you have that approval. So I would recommend highly that you begin the process of amending that APD if that's where you want to go.
And John, one of the reasons why we put it at 80-20 was because we thought that in some aspects of that, CMS would come back and say, sure, this portion we'll fund at 90-10. And this other portion, it doesn't quite fit, our rubric and our standards, so we're going to give you the standard FMAP rate. So what we contemplated was a blended, would be a project that would come in at a blended rate, which I think for a lot of this, we're going to see when you talk about interacting with the health insurance marketplace, when you talk about interacting with all these folks. I'm just saying, this committee, this task force needs to see some type of architecture that would outline that.
So, and I can't agree more. And you know that that's out of scope here, but it definitely has to be done. And at the end of the day, what you're talking about can be taken to CMS with an 1115, and here's what we're looking at creating in Arkansas, and it costs $200 million, and let's make it part of that 1115 negotiation. Would you approve it? Have it all done at the same time. And I would recommend highly that you have your department immediately begin, if that's where you want to go, those discussions and start thinking about the architecture and what it's going to include and how much it's going to cost, but have those discussions up front and get CMS to hopefully approve the idea, and even say, all right, Arkansas, if you say you're going to save this amount by doing your new program, whatever it is, we're going to give you some flexibility. So make it part of that discussion.
Well, and I give
Sen-
you,
yeah,
one
Senator,
last-
Senator, can we go on? We need to move to the next one, then you
That's
push
fine.
your button and you
We'll-
come
we'll
back.
get you.
Senator Irvin, you're recognized for a question.
Thank you. A little bit along those lines, and it was my question previously on the budget and budgetary impact, and if there's enough budget within DHS to move around and do those kinds of things. But one of the things you said is that we are paying claims, we're paying bills, but there's no data that we're deriving from that. Why is that? Because the claims that we are paying are highly specific because of the ICD-9 codes, now ICD-10 codes, it's even more specific. Why aren't we not able to capture that data currently? And one of the concerns I have as we move forward with patient-centered medical home or those kinds of things is increased reporting and paperwork burden on providers. And not being able, if we can just glean the information we can and trap that, what's blocking us from being able to do that?
Well, first, I would say that you have lots of data.
Yes.
So I want to make sure you get that impression. And what Phil is doing now is handing out to you, one of the providers in Tennessee that does their care management program, they track data as well as the state. And I wanted you to see, this is a benchmark, basically a transparent benchmark in another state. And what we were talking about early on about the data and the healthcare value and those issues is really, your state has all of the same data that this provider has in terms of, the claims. We looked at all your claims, it's there. So when you go to look at, how many women had breast and cancer screening, there's a code that pays for that.
Right.
And has that percentage increased over the past few years or months or quarters or whatever. So the first thing I wanted to share with you, with the committee, is this is what we're talking about, and start benchmarking. And so when you move to, if you go to patient-centered medical home, whatever model you use, start looking at benchmarking performance and paying for value. And again, I want to make sure the committee knows the data is available. Where you're hearing where the rubber's meeting the road is where sometimes the data doesn't match what the providers actually have in their system, and there's a lot of issues with electronic health records, and it may not be exactly a match. But at the end of the day, if everyone sits together, these states have figured it out, they can sit and meet on the common indicators that everybody can agree the data does paint the picture on these common indicators. And that's sort of what McKinsey was doing in some of their work on episodes. And I think that you can get to that level here, and I don't want you to be thinking it's an enormous effort.
No, exactly. But I mean, what I'm saying is there's no really need, in my opinion, that providers have to then go and report in addition to the claims they're already filing, because there's so much
Great.
data there.
It's a
And
great,
I don't want to increase our burden on those providers after report after report after report, or going to this portal and inputting this report on these patients. It's unnecessary when you have the high level of coding that exists with ICD-10, and regardless if you have medical records or not, your billing, practice management billing through AHIN or through any type of a clearing warehouse is going to be able to capture that data without the electronic medical record. So my point is, I mean, I think it's important for us to look at the structure of patient-centered medical homes as well. Is the purpose to get everybody onto electronic medical records and to just get data, or is it really truly to manage the care of a patient more effectively and efficiently? And I think we need to look at that and see what the goal is there. And so that's why I asked that, because I feel like, I mean, we're submitting these claims and they're high level of detail in there already, that is just something I would like to know and see if we can really refine that a little bit more. And then my second question is on page 177 of your report, you have a bubble map on your main report, and I have not read the entire report. But on your bubble map there, you have 12,622, property value greater than 100,000 people, or $100,000. That would be, I guess, lend that information to an asset test. And when you do a global waiver, when you have all the different benefit programs, do you have the ability to streamline the qualifications for all those different programs into kind of here are the parameters to meet this program? Because I know that there are different levels of requirements for each of those benefit programs. Is there a way to consolidate those kinds of requirements and add that asset management or that asset test into all areas of your Medicaid program? And could you then add in, property assessments, or how would you then verify that with another database that's currently there?
There is no asset test today.
Okay.
And could you do this with a waiver? Yes, you'd have to have CMS approval, and it could be integrated into your 1115. But it cannot run afoul of the Affordable Care Act's eligibility requirements. And that's the issue that you have today. So we recommended that you look at this as an out-of-the-box, and I think it could all be done in the vision that you articulated in your question.
Okay.
And Bob, I know you wanted to say something about the ICD issue or the
Yeah.
data.
Sure. We have been able to analyze claims with relative success. We've seen some situations where there were data elements that we would have liked to have had, but we were not able to get hold of them. Our first presumption when we run into that situation is not that the provider hasn't sent it, that somewhere along the line the database may have put it into a place where we have to go get it. And so we would look at the idea of asking providers to enter more comprehensive information almost as a last resort, because we understand how much coding you guys already do. The other thing too is that we would strive to only ask for information that you would need to submit for your other business. In particular, because Medicare is so heavily routinized, we would certainly strive to be such that if you can code such that Medicare accepts it, that it ought to be plenty good for all the purposes that we're describing, for any analysis that we do, for any dashboard, transparency, DRG grouping, and so forth. So that's always been our presumption, and we don't have any reason to believe otherwise at this point. Although I will forewarn everyone that ICD-10 is a monster, and so
You trust me.
all bets are
Speaking
off
to the
there.
choir here.
Right. And,
Yeah.
and one other point I want to make too is related to Senator Sanders' question earlier. I think John mentioned this earlier. To some extent, you folks have a bit of an advantage. I know it doesn't feel that way, but one can almost say that you guys have been cleverly and patiently waiting for everybody to do the right and wrong things, and so you can learn from them. And so to the extent that there are technologies out there, vendors out there, who are either proven losers or winners in terms of what they've been able to achieve as outcomes, certainly we're going to be gathering all that information so that you will take the shortcut to success rather than having to do trial and error. So from that standpoint, I think you're in pretty good shape.
Thank you for your answers. Thanks.
All right. Representative Dodson, you're recognized for a question.
Thank you, Madam Chair. On page 4, you had some different percentages here, and I guess my question was, of the different percentages that are of the FPL toward the bottom there, 40% had zero income. What percentage was between 17% and 100% of FPL?
We have that in the findings document. I don't have that off the top of my head, but I can get that for you. It's in here in the findings. I just don't know the exact page number.
Okay, I don't have that in front of me, so
Yeah.
I was just
If you
going
could
off
just give
your
me a minute.
slideshow.
Could we come back to that while he's looking at it?
Only
All right.
question I had.
All right, why don't we
Thank you.
do
Good
that while
question.
you're looking it up? We'll go on to Senator Chesterfield. You're recognized for a question, and I know it's a good one.
Just not excellent. Could you tell me once again what your specific recommendations were for RSMPI or whatever we call it? RSPMI. Could you tell me specifically what your recommendation was for that?
Specifically, we're recommending that there be the use of a standardized, validated, accepted clinical assessment for mental health diagnoses and severity of condition. As right now, there's no assessment based on a standardized instrument. We're recommending that be independent from any provider that would treat the person to whom they may be conducting the assessment with. And we are recommending that the benefit with a stakeholder group with expertise, that you have great expertise in the state, UAMS, psychiatry, et cetera,
You're
come
not
together.
talking about doing away with it.
No, absolutely not. We're saying that the benefit structure should be changed. It should be based on evidence-based mental health practice. It should include recovery, and it should include family involvement for children and adolescents, and it should use evidence-based practice. We also recognize that evidence-based practice in mental health is difficult to bring up because there are credentialing requirements, there are educational requirements in just about every state that's undertaken this, which is by now more than a majority of the states. You need a 3 to 5 year period of time to bring this up. But right now, your benefit structure is not in line with what would be considered evidence and/or best practice constructions.
Okay. And this is based on what observation? Visit to the sites where you have
Well,
those providers or?
in terms of the benefit structure, it's based on reading the rule and the individual codes for all the differentiations of reimbursable encounters, if you will.
All right, thank you.
You're welcome.
All right, thank you.
We were able to find that.
You were not? Well,
I
maybe-
was able to.
Oh, you were, all right.
It's at page 25 on the findings document. So it's not exactly the way 17% and above. I understand the question, there's Medicaid eligibility issue there, but the way that the department had broken it down was in chunks. 0 to 50% was 54%. 50 to 100 was 28%. 100 to 115 was 8%. 115 to 129 was 7%. And 129 to 138 was 3%. And then they further differentiate between medically frail versus regular private option. But that's in essence what the numbers are that we have in the report. And that's where we talked about a lot of analysis would have to be done to really dig down deep to get the most current updated one real time. And again, it's on page 25 of our findings.
Thank you. I'll try to get the rest of that from DHS directly. Appreciate it.
All right, thank you. Senator Hutchinson, you're recognized for a question.
Thank you, Madam Chairman. I want to talk about RSPMI, I guess, as well. I struggle with the acronym, but mental illness. We're devoting a lot of our criminal justice reform into getting our parolees and probationers mental illness treatment, which I think probably most of us think it drives a lot of criminal behavior. Certainly, I mean, we already have prior approval requirements before who's the prior approval through?
Right now, you have a process in place where a qualified person under current state rule assesses the person. And as I said, that includes demographic information, historical information as known, any medical history that's known, and a narrative assessment and a description of what the person's presenting problems are. That goes to a contracted entity, Value Options, which is right across the street. They're under contract with DHS, and they do what's a prior authorization based on the submitted information. And they do that for a range of a portion of the services that are in the billable RSPMI benefits construction. They also do it for inpatient children, adults, inpatient Medicaid paid is exempt. They've explained it's exempt from prior authorization because there is a total annual limit on the benefit, which I believe is in the 29 days, somewhere in that vicinity.
Well, this
Okay.
is probably very helpful information, but it's kind of making me lose my train of thought. So there is a prior approval by Value Options. And who are they? I mean, there's a physician who sees the patient initially.
Is it, right, there needs to be a physician in the community that signs off on the person.
And then it goes to prior authorization.
Prior
at
authorization.
Value Options. And then there's an audit if there's post-treatment, if they think it's not necessary.
I'm not aware of an audit construction in the benefit. There may be, but I'm not aware of that.
Well, my concern is if we have all these inmates coming out and we're trying to get them mental illness treatment quickly, that process already seems fairly lengthy to me. I'm not in the industry, maybe it's expedited, but it seems lengthy to me. What are you proposing to add to that process that doesn't currently exist? I know Senator Chesterfield asked a similar question,
Well,
but I'm still a little unclear. What exactly? Give me the step-by-step process of what would be added to before
Well, it
we
would be
could get somebody mental
instead
health.
of a provider that's going to provide the services, be an independent assessment. But it is a great
So
question.
who is that?
Well,
we already have Value Option doing a independent assessment.
They're not doing it. They are doing a prior authorization process, sir. An independent assessment is a clinical instrument that is standardized, validated to measure acuity, symptomatology, conditions, and a good one would be potential risk of violence.
So is that just a test that's run, or do they have to go to Little Rock and visit with
No, that can
somebody
be done,
that
that'd be
we
done in a community. It
prescribe?
could be done in a jail. The thing is about, or it could be done in a prison. The benefits can be wired for people that are in correctional situations. If the system is designed to get the person pre-approved for treatment prior to discharge. And one of the recommendations we made that is not directly related to RSPMI, but is related to the mentally ill in jail, is to put a commission together to take a look at what diversionary constructions can be made for low barrier crimes, but also look at people who are currently in jail or under the Department of Corrections supervision prior to discharge, so that the community system, if you're going to rewrite the benefits and the access, can be written so that that transfer out of the correctional environment, out of the jail environment, into the treatment environment is seamless upon discharge, so that the person doesn't have to be discharged into the community and then go through the process of becoming assessed. Because you and I both know if you don't get a person within those first 2 weeks, 30 days.
I agree.
So
I like that idea a lot. I guess I'm still trying to understand, what's an assessment? Is it, I mean, we have risk assessments in the criminal justice where they take questionnaires and fill out, and then it's
Well, it would be somewhat similar to that.
validated
Yes.
assessment, but it's not necessarily traveling to someone in Little Rock or somewhere
No.
else to visit somebody. It's just an extra
If you had,
assessment that
depending on
the
how you wrote the
physician has
benefit,
to perform. Is that
it
it?
doesn't necessarily have to be done by a physician. It could be by a
Okay.
qualified licensed person, as we discussed earlier. But that could be done in the jail or in a prison if you set the system up to do that prior to discharge.
Okay, so there could be the community-based provider could do it as well. It doesn't have to
Yes.
be a Little Rock
In a lot of
bureaucrat or
states, you
something.
have a preferred provider system, and community mental health systems. It depends on what you want. If you're using managed care, the managed care construction is responsible for the network to do that. And that preferred provider could be charged with some of the things that we're talking about in terms of trying to help a prisoner or a jail-based person who's about to be discharged to try to align their services prior to discharge.
Okay. Thank you.
Have you finished? Senator, all right, thank you. All right, Senator Cooper, it looks like you have our last question.
And following, thank you, Madam Chair. Following up on Senator Hutchinson's, isn't there a PCP provider involved in that process there? And isn't there a requirement of a certain length of time that that person has to be seen for treatment?
For the RSPMI benefit, yeah, there does need to be a physician sign-off. Does not necessarily need to be a psychiatrist sign-off.
But it needs to be somebody acting as a PCP.
Somebody with a medical license that can attest to their perspective that the person has a mental health problem.
And then there's a period of time that follows that in which they're required to be seen or something to that
I believe
effect.
it's an annual physician review.
But after they're initially assessed as needing to see someone, isn't that a shorter period of time than that?
I'm sorry, sir, I don't understand the question.
Once they're assessed to be needing to be seen for treatment, once they're assessed,
And at the prior, under the current system, the prior authorization is
Yeah.
approved by values, yes, the person can be seen.
can be or required to be.
Right now, I believe this is not a mandatory system. It's a voluntary system.
Okay.
Now, one of the advantages of the current model you have, frankly, is that being that you have providers doing the assessment themselves on whether or not the person meets eligibility criteria, that is pre-authorized by Value Options, it's more likely that the person is going to be seen by that provider quickly once the prior authorization comes from Value Options.
Okay, thank you.
All right, thank you. No other questions from the committee? That's a question in itself. Last chance. All right. All right, Senator Stubblefield, well, you can have the last question.
Thank you, Madam Chair. You know, after sitting here for 5 hours, I'm more convinced than ever that of the fact that government should not be involved in health care. You know, you stated, we were led to believe that once the private option was instituted, that emergency care or emergency room visits would be less among the private option enrollees versus traditional Medicaid enrollees, and yet your report says just the opposite.
Yes, we did look at the data, and that's what the data showed. But what we had heard, actually went one step further and spoke to the carriers, because we felt the same way you did, Senator. And it was,
I didn't feel that way.
well, it was unusual for us to see that, because usually that trend you see in the Medicaid population. However, and we said this in the report, these are individuals, by and large, that have never had health care, most of them, and they're not used to the system, and there's not a lot of outreach, or it's not really, you know,
There was not any
education.
educational,
What's that?
there was not any education as far as
Yeah, so
educating these people.
But what the carriers did tell us, which I think is really important, is you got to give it its time. You've got to let it, you know, let's see what happens over the span of 2 years instead of a year and a few months. So we recognize that, and we said that in the report. So I think you're going to see a difference. But again, I would really like you to be thinking about, if you go forward, to benchmarking that routinely, and hold the carriers responsible too. You know, at the end of the day, they need to be able to really effectively do care coordination that you're calling upon them. You're paying them a PMPM, and, you know, the question is, you have agents out there too that they're paying. You could do a lot more in that area, and both of our options have a lot more targeted towards that first primary care visit. And that's where the education will happen as well.
Right. Thank you, Madam Chair.
All right, thank you. All right, ladies and gentlemen, we have no other questions from the committee. I do want to make a couple of announcements. Please write down October the 20th at 10 a.m. That will be our next meeting. Then November the 10th at 10 a.m., November the 24th at 10 a.m., December the 16th at 9 a.m., December the 17th at 10 a.m. And I want to thank the Stephen Group for just answering all these questions and for your presentation today. And thank you, committee, for your attendance and those great questions that you had. So thank you very much, and we will see you October the 10th.